Hello everyone and welcome to this presentation. I'm Juan Rosa, a member of a scientific team of the Health Informatics Department at Hospital Italiano de Buenos Aires. In this opportunity, I'm going to describe the development, implementation, and initial results of CDS's recommendations for patients at risk for hereditary breast cancer. The structure of this presentation is organized into 4 sections. Introduction, which contains the why and the justifications of the research. Methods, where I'll describe how, when, and where we made this project. Results, with our findings. And finally, discussion, where we will focus on the analysis of the whole process, interpretation of results, limitations, and strengths of the study. Breast cancer is the most common type of cancer in women around the world. Each year, 1.15 million cases are diagnosed, representing 23% of all cancers diagnosed among women. The greatest challenge is to identify preventive strategies that reduce the morbidity and mortality associated with this disease. The discovery of the tumor suppressor genes BRCA1 and BRCA2 has radically transformed our understanding of the genetic basis of breast cancer. Germline mutations in BRCA1 and BRCA2 are responsible for 25% of the risk of familial breast cancer and therefore 5 to 10% of all breast cancers. In addition, pathogenic variants in BRCA1 and BRCA2 genes are associated with an increased risk of developing multiple types of tumors, such as ovarian cancer and pancreatic cancer. Identifying a hereditary cancer syndrome in the patient and/or his family allows physicians to provide personalized care, cancer risk assessment, as well as preventive and screening strategies to reduce morbidity and mortality associated with the development of malignancies. Currently, the large amount of new information physicians must know in order to attend patients appropriately, added to the limited time assigned to consultations in most healthcare scenarios, can lead to the generation of medical errors. In this setting, clinical decision support systems can provide active help. These systems represent one of the greatest benefits of electronic health records. They can assist physicians during the consultation, prevent medical errors, and provide active help on the patient-professional interaction. The aim of this work is to describe the development, implementation, and first results of CDSS for referral to genetic counseling in patients at increased risk of pathogenic variants BRCA1 and BRCA2 genes. The place where we carried out the project is Hospital Italiano de Buenos Aires. This is a non-profit healthcare academic center that carries out 2,800,000 outpatient consultations per year. Since 1998, the hospital has run an in-house developed health information system. Our EHR is a fully implemented web-based, problem-oriented with terminology web services. Not only members of the Health Informatics Systems department work in this project, also there were 2 fundamental parts in it. On one hand, ProCania, a hereditary cancer program integrated by physicians who research, test, and apply strategies for the promotion, prevention, and treatment of hereditary cancers, including those linked to BRCA1 and BRCA2 genes. And on the other hand, Genome IT, a multidisciplinary team of experts in health, data science, and software development who apply personalized medicine through genetic and genomics. The risk criteria for pathogenic variants in BRCA1 and BRCA2 genes were extracted from the NCCN guidelines. 4 risk criteria were selected: diagnosis of breast cancer in women under 46 years old, diagnosis of breast cancer in male, diagnosis of ovarian cancer, and diagnosis of pancreatic cancer, regardless of sex or age at diagnosis. For each of these 4 criteria, a subset of problem was created, which include all the pathologies associated with each condition. The reason for selecting these criteria is because they correspond to patient personal history. This type of data is registered more frequently in the patient's EHR than, for example, patient's family history or other types of information. The CDSS takes as input the problem registered in the patient's problem list related with the previous criteria, the physician's specialty, including family medicine, internal medicine, gerontology, oncology, general surgery, and gynecology, and the type of consultation which must be scheduled previously. The exclusion criteria were selected were the record of a previous genetic counseling interview, an already scheduled appointment with the genetic counseling team, and a genetic test on the EHR. The rule will not be activated again for a period of 1 year if the alert was previously rejected by that user. The CDSS were designed to be triggered in real time after 3 different actions or hooks in the clinician's workflow on the EHR. These hooks are patient view, when the professional enters in the patient's EHR. This one is exclusive for general practitioners. Condition create, representing the creation of a problem in the patient problem list, and progress note access, when the professional performs a problem-based evolution. To achieve the integration of the different system, FHIR and CDS hooks standards were used. The architecture of the solution was made up of the following main components: the FHIR server, the CDSS, which uses rules for the rules, SNOMED CT for model knowledge base, and the EHR. Once the physician is in the scheduled consultation, either in person or using telemedicine, the alert will differ depending on the professional role and the interaction with the EHR. When the professional practitioner accesses to the patient's EHR with a problem from the subsets, the alert appears directly with their options already displayed. In the case of specialists such as gynecologists, oncologists, and surgeons, the alert will appear in a passive way when the physician is creating a problem or making an evolution related to a problem included in the corresponding subsets. In the last case, when the physician clicks on the image with the bulb, the complete information of the alert is displayed. The reminder has the following elements: a button to close the reminder, the related problem in the EHR, a mention of the increased risk possibility of pathogenic variants in the BRCA1 or BRCA2 genes, a suggestion for genetic counseling, 2 buttons either to accept or refuse the recommendation, and a link to a document with more information on hereditary cancers related with BRCA1 and BRCA2 genes alterations. With the recommendation, the user can perform 4 main actions: accept, refuse, close, or ignore. If the physician accepts the recommendation, a genetic counseling interview order is automatically created. In addition, a link with more information for the patient is offered with the steps to be followed, such as how to get an appointment or what information should be collected before the genetic counseling consultation. We perform a cross-sectional study with information regarding the CDSS interaction from January 2021 to April 2021 in our institution. A total of 142 alerts were triggered by the system for 72 physicians in 98 patients. Of the 142 alerts, 101 correspond to patient view, representing 21%, 30 to progress node access, which is 21%, and 11 to condition create, that is the 8% left. Only 3 alerts were accepted, all of them corresponding to the patient view hook. The other remarkable aspect is that none of the alerts were refused. If we classified the interactions by the medical specialty, The majority of the alerts were triggered by general practitioners, special family medicine, and internal medicine. Also, the ones that were accepted correspond to these specialties. The other specialists didn't accept the recommendations, although none of them were refused. In relation to the patient's diagnosis, each of the alerts correspond to a different diagnosis. Breast cancer in female under 46 years old, ovarian cancer, and pancreatic cancer. The alert in breast cancer in male patients was activated only once, which is expected taking into consideration its low incidence. Regarding discussion, the first thing to mention is the effectiveness of the tool, 2.1%. Findings are similar with previous studies' estimations, where as many as 96% of the alerts are overridden. Some researchers suggested that over time, alerts override become habitual. This behavior is activated by environmental cues and repeated automatically, without conscious intentions. Also, some studies observe that the effectiveness varies according to the intrusiveness of the alert. All the accepted alerts correspond to the patient view hook, while in the progress node access and condition create hooks, no acceptances were registered. This may be due to the fact that the alert in patient view is an active intrusive alert, unlike the others. There were some limitations in our study that we must address. First, this was a single-center study. Also, the short period of time, we consider only the first 3 months since the implementation. This period could be not enough to obtain a representative result of the effectiveness. About the strength of our study, we can mention that we create a multidisciplinary team composed of informatics, engineers, physicians, and geneticists. As to the architecture and the interoperability, the tool was created using international standards and service-oriented architectures, implementations that adopts existing web-based technologies such as RESTful APIs to share information between systems. This corresponds to the 5th phase of the right model of CDSS evolution, the highest state currently. In the future, we'll intend to feed the genomic database of our institution with the information collected from the genomic test indicated with the help of these and other CDSS. This genomic database will also be used in new CDSS tools with follow-up rules for patients with pathogenic variants in multiple genes. As a conclusion, we can say that the implementation of a CDSS tool using an electronic alert could enhance patient care through personalized medicine, contributing to and accelerating the early detection of pathogenic variants in the BRCA1 and BRCA2 genes, with an impact on the patients and their families' health. Finally, we would like to acknowledge ProCane's team members, especially Maria Cecilia Ricci, for their contribution to the development of this CDSS. I will be available for any questions or comments you may have via email. Thank you very much for your time.